we will be moving on to the final symposium for the day, symposium number 4, looking at some of the important but not so discussed aspects of the maternal respiratory health. High-risk pregnancies, how to avoid and how to manage. To moderate the session, let me cordially call upon Dr. Niranjan Disanayaka, President, Sri Lanka College of Pulmonologists. And with that, I'd like to call upon the following dignitaries to come up on the stage. Dr. Sundaralingam Rishikesavan, Dr. Niranjan Disanayaka, Dr. Prabodhana Ranavira, Dr. Sampath Vithanavasam, and Dr. Harshani Lenage.
Good afternoon, and it has been a wonderful session, so we will start without much delay. So, pregnancy, we are dealing with 2 lives, and probably it is stressful for the mother, stressful for the baby, stressful for the family, and certainly stressful for the professionals who are looking after the patients as well, especially every high-risk pregnancy. I think sometimes we are on pins and needles. So this is why we actually decided to discuss about these high-risk pregnancies. So without much delay, we will go for the first case. So this patient was presented as a 24-year-old mother, treated as asthma because of long-standing shortness of breath, and he had no wheezing. So, you usually put the people who are most close to you first into difficulty. So I will first put Rishi into difficulty. So, Rishi, do you agree with the diagnosis of asthma with this X-ray?
Thank you, Niranjan. So this is a 24-year-old lady treated as asthma, and once you see the important, there is no wheezing. So short of breath, there is no wheezing. Once you see the X-ray, what you can simply appreciate is there is a prominent pulmonary vasculature. So first we have to think about, as is treated as asthma, no wheezing. Pulmonary hypertension is the first thing come into the mind. So patient need to be assessed for the causes for pulmonary hypertension.
Okay. Dr. Sampath Vithanavasam, I think you will agree with the possibility of pulmonary hypertension with this X-ray. Now, usually when we are suspecting pulmonary hypertension, because this patient didn't have wheezing, clinically are there any clues to suggest that rather than asthma, this patient is having pulmonary hypertension? What are the salient clinical features in the history of the patient that you might think about?
I think clinically rhonchi would be one differentiating factor, because the pulmonary hypertension rhonchi extremely rare, while the in asthmatic patient the rhonchi, that is clinical examination, even if you are concentrating on the history, if you clearly concentrating on the history, the precipitant factors for breathing difficulty would be different. Say, for example, asthma patient will give you a history with a cold, evening, nocturnal cough, and with respiratory tract infection, exacerbation, which is not in the pulmonary hypertension, more of a persistent type of thing. And examination, of course, is sometimes difficult. Loud second heart sound would be a good thing, but of course, it's extremely difficult even for expert to pick it up sometimes. Those are few things. And looking at the X-ray, of course, here you can see hilar prominence, which again gives you a good clue. And the best, probably the easily available test is echocardiogram for us. So if you do echocardiogram, there is a minimum chance of missing significant pulmonary hypertension. The issue is sometimes with regards to the pregnancy, the problem is sometimes we underscore the pulmonary hypertension at the beginning, the severity, which can be progressive and much more severe towards to the second and third trimester. That is a pitfall, because even for us, for our colleagues, cardiologists, when you have mild form of pulmonary hypertension, sometimes things without further investigation that this patient is fit for pregnancy and probably a fit for.
Regarding syncope and palpitation, are they specific for pulmonary hypertension? Syncope and palpitations on exertion?
Syncope is a rare symptom actually, but breathing difficulty is I would say the commonest, because the most of the pulmonary hypertensive patients at the beginning asymptomatic or NYHA class 1, basically class 1, even with the moderate pulmonary hypertension.
Yeah, so well, mainly they will come with non-specific shortness of breath, and you might have to, think about the possibility of pulmonary hypertension, especially in the clinical.
Definitely.
Definitely. So if this patient came to you, probably you will have a ECG at hand as well. So you will be, as you said, you will be assessing with a transthoracic 2D echocardiogram. So how sensitive it is in a normal person to identify pulmonary hypertension?
Yeah, usually even milder form of pulmonary hypertension, we see sometimes, not sometimes, it's the majority of the cases, quite significant tricuspid regurgitation. But the pitfall again here is the echo machines that we are using island-wise, especially the private sector, rural areas and so on, is not very accurate. It's not sensitive enough. Sometimes even in the DMH, if you say this is a tertiary care center, we don't have a state-of-art cardiology echo machine. We are using just a basic machine, and we need color Doppler and the very accurate continuous wave Doppler to assess this type of patient. And sometimes it's extremely difficult to blame a cardiologist or a the other medical officer who is doing echocardiogram missing this type of subtle changes in peripheries. So then we have to provide adequate hardware. And then, of course, if you have adequate hardware, I don't think that is a difficult task for a well-trained person to pick a significant tricuspid regurgitation.
Yeah. Considering the consequences of pulmonary hypertension being missed, especially in pregnancy, I think probably we need to pursue more about getting with these good quality machines, isn't it? Yeah, because the other diagnostic one would be the invasive pulmonary artery catheterization, which might not be feasible in all the patients.
Yeah, actually, if you have significant pulmonary hypertension, it's difficult to miss in echocardiogram because RARV almost indefinitely dilated. But the other pitfall that most of the people know, you know that left ventricle is bigger, right ventricle is smaller in a normal heart, but right heart becomes equal size of the left heart, considered that the right heart is bigger. Right? Yeah. So, which is sometimes straight away in a busy clinic, those things can go miss, unfortunately.
Yes. Thank you very much. So now I come to my friend Prabodhana. Okay. So we are confident that the diagnosis of pulmonary hypertension is there. So as an obstetrician, this is a female, 24-year-old, coming to you before pregnancy, and she's asking whether she can become pregnant. What are the factors that you will be highlighting, and what are the factors that you'll be looking for?
Right. So now for any cardiac or any medical disease, we go by very simple principles as obstetricians. So it's always mother's life first. So we compromise the baby for, if there's a need to save the mother, we have to compromise the baby. It sometimes involves performing sterilization for a woman who has never had a baby, or even doing termination, or even terminate a pregnancy at a very, at 22 weeks, 24 weeks, or even prematurely. So it's always, and throughout the whole discussion we were talking about X-rays and all that. So if it is need arise, there's no need to hesitate. So always mother's life first. And the other things are reproduction is a need. It's as we all are animals in some ways, right? So in a normal nature's way, we are animals. So one of the basic, being a biological entity, is to pass on their gene. It's a need. It's a biological need, and also it's as recognized as a right by the the current thing. So when somebody asks, when we can pregnant, we have to give them a proper advice. And at the end of the day, it's her choice. We don't play God. So sometimes we have seen many cases where they have become pregnant and died, and giving out a baby and go in alone, right? So that's, I mean, when we ask for a term, we do a lot of termination in dysoisa, and some women will say, no, we want to go ahead with it, and I know that I'm going to die, it's fine. And we know that there are prominent, prominent people in the known society who have, declined treatment to save the baby and then died, right? So one of the prominent politician's daughter died, giving, declining treatment for breast CA. So this is a common thing to happen. And especially in our society, sometimes, the people say you can do everything for your baby and then they might die. But to answer, if we are to give the best of the care, it's always better that we have a team, right? So in our, especially in SOISA, we have a very good team. We talk to each other and we manage them as a team. So we have a good outcomes most of the time. So that's how we go it. So if a person comes, so we have to get, first some part to see what is the diagnosis, proper diagnosis, and there we go the whole scenario and then get a proper diagnosis, and then we use, now it is to cardiac things. We have this, if you go to the next slide, So basically, if a patient comes either pregnant, let's say now in our societies, usually they come after pregnancy rather than preconceptional counseling. So these are the questions as obstetricians. So all the trainee obstetricians here, these are because we are not medical people, and most of our patients are very happy and healthy. They are young people, right? And so when we usually forget our medicine, surgery, all the pediatrics, everything throughout the time, because we usually deal with healthy people. So when it comes, if I don't know about it, so the first thing is it a bad condition? Sometimes there are heart diseases that you never heard of, respiratory diseases sometimes we never heard of. So I want to know whether it's a bad condition, so that I may not be able to answer that question. So we do the proper referrals, or we get a proper expertise. And then after that, if she comes in a pregnancy, we want to know whether she can continue, whether she's going to die, or what is the prognosis of the disease. Then how can we optimize, if you are going to continue the pregnancy, how can minimize it, how this disease will affect the pregnancy, how this disease will affect the baby, how the pregnancy will affect the disease. So these are the questions that we usually ask. And then at the end of the day, I want to know, when am I going to deliver, how am I going to deliver, what am I going to do until then, and then during the delivery, whether it's a cesarean or normal delivery, what can we do to reduce the complication, because we know it's a demanding situation. And soon after delivery, the postpartum period, how can take care of her. And the more important question, can she get pregnant ever again, whether we need to do something. So those are the questions that we usually answer.
Yes, thank you, Prabhu. And I think you highlight a very important point. Reproduction is a right of a person. So probably because we are afraid that as a professional that the patient might become pregnant and it might cause problems to us. If there are no significant contraindications, we can't actually discourage because of that only. Yeah. And we have to support her decision as much as possible, provided that she understands the risks and the benefits of the condition. So that's a very good point that you raised. And these points actually will be repeated during the next 4 or 5 conditions. So hopefully I think you have given a very good outline about this. Right. So I think you wanted to talk about how to measure the severity.
So if it is come to cardiac disease, we use what you call the WHO modified the prognosis tool. So they have categorized cardiac conditions into 4 categories. Some people who have no problems, to the class 4 where they can have a serious issue. So if you go to the next slide, so these are how they categorize the cardiac conditions. So if you look at it at the class 4, pulmonary hypertension of any degree from any cause is considered as a class 4, where they have an extremely high risk of maternal mortality or morbidity. Right? So, I mean, in that case, if somebody comes with pulmonary hypertension pre-pregnancy, we should tell them, you can't get pregnant. And if you come pregnant, then we have to decide what to do.
Yes. Okay. So I think we have, the changes that have been occurring in the pregnancy as well as the types of pulmonary hypertension in this slide. Probably Dr. Sampath can highlight the types of pulmonary hypertension, the 5 types.
Actually, clinically, 5 types are there. The first, of course, is pulmonary. We are talking about pulmonary hypertension. Sometimes the words is better to keep in a pulmonary hypertension. 5 types, right? The first thing is pulmonary arterial hypertension. Then the second thing is pulmonary hypertension, not the pulmonary arterial hypertension secondary to pulmonary hypertension second to heart disease, usually left heart disease, not the right heart disease. Then thirdly, pulmonary hypertension secondary to the lung disease. Fourthly, thromboembolic diseases, right? And fourthly, miscellaneous causes like hematological and so on, right? So but out of those stuff, probably second and the third categories are commoners that we are dealing with. That is pulmonary hypertension secondary to left heart problems and the pulmonary hypertension secondary to the lung problems, right? And the other causes, even the pulmonary embolism is 0.5%, I think, less than, even in pregnant women, the chances. So those are very rare even in pregnancy. So then again, the other classification, I'm not sure here whether we have it, depending on the investigation findings, we can classify it for pre-capillary level and the post-capillary level, right? You know that pulmonary artery, then pulmonary capillaries, then pulmonary veins, which drains to the left ventricle, left atrium, right? So then if there is anything, any problem in the left ventricle level or left atrium level which causes back pressure, that causes, right, pulmonary capillary wedge pressure increment. That is actually post-capillary, right? Before the origin of the capillaries, that pressure origins, right? So those patients, pulmonary capillary wedge pressures is high, right? Which is very important factor for us to decide correct management of this patient. Then the pre-capillary is the arterial level. That is which we call pulmonary arterial hypertension. To correctly diagnose this, we have to do right heart catheterization. Echo this chest X-ray and can't differentiate between these two. And the another entity is there where the mixture, pulmonary pre-capillary and the post-capillary, both entities in the same patient. So those are the basic three categories that we need to understand to decide the correct treatment, because the treatment that we have mainly for pulmonary arterial hypertension, as you can understand, the pulmonary artery is made of smooth muscle and all the treatment directed for vasodilatation. So no point giving all those treatment for the post-capillary level patient, that is where the pulmonary capillary wedge pressure, the patient whose pulmonary capillary wedge pressure is increased. If it is the only problem, we have to sort out at that level, not at the pulmonary artery vasodilatation level. So I think you might have understand this is symptomatically, you can see 5 categories, basically pulmonary artery hypertension, pulmonary hypertension secondary to lung left heart disease, pulmonary hypertension secondary to lung disease, pulmonary heart hypertension secondary to thromboembolic problems, and the miscellaneous causes. And by investigations, you can understand post-capillary, pre-capillary, or a mixture. The identification, this pre-capillary or post-capillary level pulmonary hypertension is important for us to deliver the proper care. Unfortunately, very, very sad to say, for our setup, we are not doing right heart catheterization to diagnose pulmonary hypertension. By definition, you can't diagnose pulmonary artery hypertension without right heart catheterization. So we have a lot of loopholes in treating pulmonary hypertension.
Okay, so thank you very much, Dr. Sampath. Then this patient now, when she becomes pregnant and comes to you, as as Prabodhana correctly said, almost all of the pulmonary artery hypertension categories are contraindicated in pregnancy. So as an anesthetist, may I ask you, what are the concerns? So if the patient comes with pregnancy, we might have to decide whether to continue the pregnancy, terminate the pregnancy, or deliver the patient. So, in an anesthetic point of view, if we consider terminating the pregnancy or delivery of the baby, what are the considerations that you would have in a patient who is already pregnant and comes to you?
When the multidisciplinary team decide on the termination, like after the POA of 34 weeks, probably they will decide on whether to take the baby out, because now then it is a challenge to the anesthetist, because now with the pulmonary hypertension, these patients are with the physiological changes in pregnancy, the oxygen demand is already high, and these patients are hypoxic, and so we have to maintain the cardiac output in perioperatively. So preoperatively we have to optimize with the existing cardiac status by the cardiologists and the respiratory physicians and the VOGs will optimize the patient. Of course, patient should be in the ICU, and then now in anesthetic point of view, we have to maintain the cardiac output perioperatively. So we have to decide on the mode of anesthesia accordingly. So for that, we have to have perioperative aims. So we have to maintain the cardiac output by improving stroke volume and the heart rate, and the factors which increase pulmonary vascular resistance should be avoided, and adequate oxygenation, because it's hypoxia will cause further increase in pulmonary vascular resistance. So we have to maintain the cardiac output by maintain the stroke volume, which is have to maintain the preload. Adequate hydration, adequate preload is necessary. And then the afterload, because primary, this might be secondary pulmonary hypertension with the ASD, VSD or the shunt fraction, so we can't decrease the afterload. So we have to avoid decreasing the systemic vascular resistance, because if it is decreased, the shunt will reverse, and sometimes we are there with bidirectional shunt, so we have to be careful on that. And then the contractility should be maintained. The heart rate should not go up, because with increasing oxygen demand and they are maximally compensated, so there will be a problem. So, and the factors which increase pulmonary vascular resistance, the hypoxia, hypercarbia, acidosis, hypothermia, and anxiety, fear should be avoided, and oxygen, right? So, so to think of the mode of anesthesia, so mild to moderate pulmonary hypertension patients, you have to, of course, confident, we have to build up, so anxiety, fear should be relieved, and graded epidural is, we can manage, because we don't interfere with the respiration. Right? If the patient is failing hard, can't lie flat, then of course we have to think of general anesthetic, cardiostable general anesthetic. Of course, for both the ways, we have to have invasive monitoring, intra-arterial, continuous intra-arterial monitoring, central venous pressure monitoring, because we know the targets. Early observation and early intervention at the correct time is necessary with the drugs and the fluids.
Thank you. So, you know, we actually, yes, please, yes. Yeah.
Can you go back to WHO categories, if possible, please?
Yeah.
Just right. And with the causes, the other one, yeah, of course. Now, if you look at this now, what I'm telling, what Dr. Prabodhana said, he said it's a right for a pregnancy. Now, if you can see, we are in a way, we are telling each and every patient with pulmonary hypertension should not become pregnant. And actually our colleagues are doing that. They are asking not to become pregnant. But looking at the first part, WHO 1 and 2, they say uncomplicated ASD, uncomplicated VSD, uncomplicated PDA, everything is there. But indefinitely, these patients having pulmonary hypertension, even though it's uncomplicated and asymptomatic. Say, for example, if a patient comes with ASD, their pulmonary artery pressure somewhere around, if you measure in echo, it will measure somewhere around 30, 40, 50, even sometimes 60. So indefinitely with the ASD patient will come with a report from the cardiologist, moderate size ostium secundum ASD with mild to moderate pulmonary hypertension. are the practical problems. Patient comes with ASD with mild pulmonary hypertension. So what we are going to do for these patients, are we asking them to not to become pregnant? So they are the problem asked. So now this type of patient, if you get this type of patient, especially pre-pregnancy, it's very important for you to, just because of looking at the echo report, not to say that you can't become pregnant, because you need quite a lot of investigations, right, to say that the patient can't, to say not to become pregnant. Otherwise, I feel it's a crime. Even I think this is a community. Even as a cardiologist, I have seen a lot of cardiologists say, "Don't become pregnant. Don't become pregnant." So I don't think that's violating the same right the Prabodhana explained. Yes. So for that type of patient, I will just explain. The first is symptoms, whether the patient is symptomatic, right, and how severe the pulmonary hypertension, right, and whether the right heart is affected or not, right, and if all those things were there, then echocardiogram finding, and the BNP is a useful tool to see how much stress that lesion gives to the heart, right, and the 6 minutes walk test, exercise CCD, right, and if a patient can't go for exercise CCD, VO2 max, right, which we don't have, but just to see the advanced level of investigation, and finally the right heart catheterization at laboratory. So after getting all these details only, you ask patient not to become pregnant. I feel, as you said, otherwise it's a crime, and it's not an easy decision.
Just to add to Dr. Sambat, the CPAT now we are doing at NHSL, so we can do the VO2 max there. We are starting.
And there is a decision, termination of pregnancy or continuation of pregnancy. We are actually discussing about pulmonary hypertension a little bit more, because all of the other conditions that we are discussing will have a component of PHT. So that is why. So termination or continuation.
Yeah. So now if we come to cardiac disease, we use this, what we call, we are approaching, now cardiac disease is my special interest, cardiac disease, complete pregnancy. So now if you look at this, the whole of the cardiac lesions, the problem is cardiac output at the end of the day, because in pregnancy there's a rise in cardiac output. So now if you look at the blue line, now what we have a very simple way of simplifying this. Now until 16 weeks, if you see that, you know that the cardiac output rises to a certain level. So now if a patient comes before 16 weeks, and then we know there's a condition which by increasing her cardiac output we know that's going to go up, and at the moment she's suffering, like let's say she's in already heart failure, NYHA class 3 or 4, we know that she's not going to tolerate this pregnancy in the future. So with the help of the cardiologist, which we what we do have, we have an MDT, the cardiologist will agree that this is going to be high risk, and sometimes we get a second opinion. We try to give the chance to the mother, and to obstetrician discuss, and then we agree for a termination. So until 16 weeks, if they come early, we tend to do a termination if there is a cardiac disease which is associated with the bad prognosis. Now if they come, let's say 18 weeks or something, we know that she's already tolerating the pregnancy, and until 28 weeks the cardiac output more or less may remain the same, unless there are infection or some other problem. So if we can maintain that cardiac output or that level until 28 weeks, we tend to do a delivery at 28 weeks, because 28 weeks baby has a chance of surviving. So that is our way of managing. Now if they are at 28 weeks, they are tolerating pregnancy, we know there is a slight increase in cardiac output due to increased heart rate from 28 to 32 weeks. From there, so we go by one to decide what's the ideal time for delivery depending on their symptomology. So we will be assessing regularly the cardiologist, and depending on that we take a joint decision when to deliver. So it comes to termination before 16 weeks, and after 16 weeks to 28, termination of pregnancy, and continuing the pregnancy carries the similar risk. So we try to give a chance to the baby.
Thank you very much. And I think the timing of delivery. Yes.
Right. Okay. So same, I was just about to tell about that. So if you look at it, now if now when somebody is going at, so the first thing is at 28 weeks, as I told you, if that further increase is going to cause problems, or at 28 weeks she's already having symptoms, we deliver. Then comes 32 weeks, baby has more chance of surviving. And somebody at 32 weeks survive little, we try to push another 2 weeks because the chance of going to PBU is very much less. And at 34 weeks, we tend to deliver, because if you have a like now, I always kind of take the Damayanti Darsha for, you know, the runner, right? So now pregnant mother at the time of pushing, she's like Damayanti Darsha doing the last 100 meters after her 400 meters, right? And she will stop in a few seconds, but she will go on till hours and hours in the labor, and also what you call during the pregnancy for 24/7 for 284 days she'll be doing the 400 every day, right? And a woman who have never done any exercise in her life, competing with a Olympic player. But I mean, what Damayanti Darsha can't do when she's not pregnant, a pregnant mother is doing. So if we ask Damayanti Darsha, she stops after 400, no, run again. She comes and stops, no, run again. That's what we are doing if we are continuing the pregnancy. So at 34 weeks, if we think, okay, everything's okay, she's a very high-risk woman, we tend to deliver, and we are the cardiologists, the anesthetist team, the postpartum care, everybody get together, and then we do a delivery. So if everything okay, we continue the pregnancy, right? 36 weeks, 37 weeks, depending on the what cardiac condition and how she's tolerating the whole thing.
Okay. Thank you very much.
Can I add one word? Yeah, just to add Prabodhana. Now, he said between 18 weeks and 28 weeks, no much of increase of cardiac output, no much of increase of the volume. But one thing that you have to keep in mind, now rather than Damayanti Darsha just running one round, now she is continuously running.
Yeah, that's it.
Right? She is continuously running until up to 28 weeks, right? From 18. So definitely, indefinitely is more stress to the heart rather than 19 weeks. It's more stress in 20, more stress in 21 is going to be added on. The heart getting tired, mother is getting tired. So the trick here is you need to monitor these patients very, very closely. Where their critical point is, where they can't tolerate. Most of these patients are bearing up, holding up to certain level, and once they started to deteriorate, they deteriorate like nothing. So we have to find that the point, whether when that point comes. If it happens at 22 weeks, probably delivery may be at that point. Yes. If that happens 24 weeks, and for trick behind that is you need very, very careful monitoring and cardiac care. And actually, it's extremely difficult to do in a periphery where the not a hospital where the pregnancy is their priority.
Yes, yes.
So that's the problem.
Yeah, and now the main problem that arises in my mind is now we know that the transthoracic echocardiogram is not a very sensitive measurement to measure the deterioration, isn't it? So what are the other things that we can use?
No, transthoracic echocardiogram is very sensitive tool because if you know the baseline, you can see how the RV function deteriorates, right, because we can measure the RV function. We can measure now if you know at the tricuspid gradient at the beginning 30, and if it is 22 weeks, if it become 40, 23 weeks 50, then 60, then 70, then right heart start to phase. We know indefinitely going to be a problem. And if we have a bad patient, we do BNP at baseline level, right? So the BNP above 600 is a ominous thing. Yes. So you can almost 50% chance that this patient gives rise problems, right? So then we are measuring, depending on the patient's problem, either monthly or a 2-monthly BNPs. Right. So that gives idea how the heart hold the stress.
Yes, thank you. Right. So cardiac output in labor, I think we have discussed, and principles of care of undergoing vaginal delivery. Yep.
So again, now once we started the proper care, now earlier and when we were medical student, if it is a cardiac disease, almost more than 90% would have had a cesarean section. a planned cesarean section with combined epidural, lot of things. But now most of our patients will have a vaginal delivery, including pulmonary hypertension. And actually, if you really look at it, having a vaginal delivery is far safer than a cesarean section, where there is a chance of, because of the anesthesia can drop pressure, there can be heavy, postpartum hemorrhage is high in cesarean section, so all that can deteriorate patient very quickly. So it all depends on whether she can push, whether she can do the Valsalva maneuver, whether she can tolerate that, because during the pushing she increases her cardiac output from baseline to 80%. So whether she can do that. And during labor, we try to do what we call vacuum delivery, or we reduce the shortening or pushing, so that we reduce, and proper pain management. By doing so, we reduce the increase of cardiac output. But first, we have to decide whether she can increase that. If she can increase that cardiac output, she can tolerate that, we go for a vaginal delivery. If not, we do a planned cesarean section. And we tend to do something called planned vaginal delivery. We don't like, now when you say planned vaginal delivery, it can happen at 12 midnight. But there are, anywhere in the world, the staff is less and we are not up to our optimum. So we try to do is at a planned vaginal delivery, where we look at the Bishop's scores. If the patient is favorable for induction of labor, it's rather than induction labor, it's just we break the waters and the labor starts almost automatically. So we continue very close monitoring, and it's usually patient goes to the ICU. And DMH is one of the DMH, and I don't know where the castle happened. DMH is one of the ICUs which vaginal delivery happens inside the ICU. Most of the place I see during the delivery they taken to the labor room. So here we do that there, and our outcomes are we experience we are better off. So what is this principle of care? So this is about the after delivery. So after delivery is where things go wrong, because when the placenta separates, 500 ml of blood comes back to the system. So where that volume overload will cause the right heart to fail and all that. So meticulous fluid management, copious furosemide, all that, because this has to be a very big balance, especially in pulmonary hypertension, because if you drop the systemic blood pressure, if there's a shunt, it will turn other way around. So right to left shunt, I mean, it's very difficult to reverse it. So then due to the anesthetic, the cardiologist has to go all over the place, right? But if he can reduce that, then it's okay. So the anesthetist team plays a big role. The minute-to-minute monitoring and minute-to-minute management will occur.
I think it's time for you to give us just an outline about how postpartum, the anesthetic team. Yes. Postpartum, the patient has now come after the delivery or probably the termination to the ICU. So first day, how would you, basically go on with the monitoring and the management?
Yeah, the invasive monitoring, of course, will be there, continuous monitoring, and oxygen should be there, because post-op oxygen therapy, patient is in oxygen therapy, so gradually tailing off oxygen, and epidural pain relief. If it is normal vaginal delivery, we will put a labor epidural and we'll give her good like T10 segmental level to L4 good pain relief, so that she will then post-op continuation of the pain relief because pain per se increase pulmonary vascular resistance. So
pain management, meticulous fluid management, oxygen therapy.
Yeah, restricted fluid management with the IVC collapsibility, and checking and not to overload, not to underload, and maintain the cardiac output and also preventing air bubbles going into the circulation.
Okay, thank you very much. So I think we will go for the contraception in a bit. Yeah, and so 3 or 4 causes respiratory. Now, this patient was with pulmonary hypertension. We were talking about the primary pulmonary arterial hypertension, and as you said, respiratory causes are common for developing pulmonary hypertension. Rishi, not to miss respiratory causes?
Yeah, not to miss. In this X-ray, it's obvious there is no ILD or bronchiectasis, but those are the common condition in lung context, post-TB bronchiectasis, interstitial lung disease are common context. But the most of the time what we miss was obstructive sleep apnea. So it's a common thing, but it's underappreciated. So if we couldn't find any other causes in obese patient, And with the pregnancy, we will have some slides about that. So that also the important cause of pulmonary hypertension. So we need to do the lung functions as well as the and the sleep study if lung functions are negative.
So many of the causes, as you said, will be seen in a chest X-ray if taken, isn't it? Most of them, in the physical examination, it will be there. But if you can't see anything, you might have to think about the primary pulmonary arterial hypertension and the arterial pulmonary hypertensions, as well as you said, obstructive sleep apnea, obesity, hyperventilation.
And also other modalities like the connective tissue disorders.
Yes.
That also need to be looked for.
So another challenge. This is actually a 19-year-old girl currently admitted at the ward. So this is X-ray. And because the next topic will need this introduction, 19-year-old girl with this X-ray, Dr. Prabodhana. And she wants to become pregnant.
So for me, now as I told you from the beginning, so this is like severe thoracic, there's a curve, so kyphosis or scoliosis, and in a way, so it's more challenging. If she can get pregnant, then most of the problems are okay, because then she can, all the other problems are sorted, and then the orthopedics and the respiratory. So how much is the respiratory system is compromised. So again, they will do all that we discuss about the lung functions and all that. Then with all that idea, I think most of the respiratory diseases, as far as I know, apart from very few, they can tolerate the pregnancy very well, unless there is pulmonary hypertension or their cause.
Yes. So this gentleman, just a few words about the thoracic skeletal abnormality, because it is not rare, isn't it, Rishi? Right?
It's common. It's common, but the severities vary. So there may be from mild to mild moderate to severe. So all you can remember the Delisha's lecture in the morning, physiology. So when the pregnant gravid uterus pushing the abdomen up, then there's a anterior posterior diameter increase in the normal person. But in a patient with this skeletal abnormality, that won't happen. So that will going to compromise the respiratory function when the gravid uterus pushing up. So what limit it can go? That's a thing, but we have to decide, the respiratory physician, and to give the information to the obstetrician.
Yeah. So just an idea about the normal curvatures. We have the cervical curve as well as the lumbar curve and the thoracic curve in a normal spine and laterally. And when you have this S-shaped abnormality, we call scoliosis, and when there is a bending down, we call kyphosis, and usually kyphosis and scoliosis occurs together. And how do you measure the severity? You told about the severity. So basically how we measure the severity is by the Cobb's angle, where you get the maximum deviated vertebrae, the angle between the maximum deviated vertebrae and from the apex. You measure these two lines, you connect these two lines and see the angle, and depending on the angle, we actually have this severity, less than 10, more than 25, more than 40, and especially if it is more than 70, that is one of the cutoff marks according to the Cobb's assessment, and probable significant decrease in the lung volume will be there, and if it is more than 100, there will be dyspnea and exertion, and if it is more than 120 in a person, there will be definite hypoventilation. So this angle measurement is very important, and you can simply do it by simply a lateral thoracic X-ray. So having an idea about that, especially when we are doing the pre-pregnancy counseling, this angle will have significant repercussions in the management of the patient, especially now, because if it is, there is an angle, there are sometimes surgically correctable. The scoliosis now, in a good hand orthopedic surgeon who is specializing with scoliosis, these can be corrected, and this 19-year-old can be told that this can be corrected and you can probably have a pregnancy later, but not now. So this assessment of severity and referring to an expert spinal surgeon is very important if this patient comes before the pregnancy. And as correctly said, I think you can see that unlike in the normal pregnancy, especially when a patient is having kyphoscoliosis, there is a significant reduction of the total lung capacity. All the lung volumes, FVC, FEV1, total lung capacity, everything reduces, and this has significant repercussions for the pregnancy as well as continuation of pregnancy. And you can see this decrease as the angle increase in the Cobb's angle increases, the volumes reduces. Right? And especially when you think about the abnormalities of the thoracic spine, when you talk about kyphoscoliosis specifically, when you consider other things like pneumonectomy and ankylosing spondylosis, you can see that a significant proportion of these patients have an FE1 and FEC less than 50%, which will have significant repercussions in the pregnancy. And I think you have some studies, Rishi.
Yeah, there are no trials actually in the pregnancy, but there are case series and studies done on the patient with hyperscoliosis. They were treated with non-invasive positive pressure ventilation because that's to keep the ventilation optimal level, and to because as Niranjan said, these patients with a severe hyperscoliosis, they can have alveolar hypoventilation that causes to nocturnal oxygen desaturation. That's going to compromise the patient as well as the child. So nocturnal non-invasive ventilation is useful in those patients. But a lot of studies have shown there is not much severe complication in moderate up to moderate hyperscoliosis. Patients usually have a normal delivery. But in the severe cases, there are other studies shows that the cutoff point is FEV1 of 1 liter.
1 liter.
So it's less than 1 liter is definitely, because at the start of the pregnancy 1 liter means when it's progress, it's going to go down.
Yes. So this FE1 of 1 liter actually is it's a marker that is used for various things, even connective tissue associated interstitial lung disease, kyphoscoliosis, a lot of things. You use the FE1 of FEC of 1 liter. It is actually according to a study in 1995 by King et al. But some people have disputed this finding of having a 1 liter FEC, but most of the people have agreed with the FE1 of less than 1 liter. Can I ask the anesthetist, if you have a FE1 or forced vital capacity of less than 1 liter, how it affects the general anesthesia? Are you worried?
In view of anesthesia?
Yes.
Now, if it is this surgery, if the patient is pregnant and we have to go on, give anesthetic, most preferable way is a regional anesthetic. Right, so we can give a spinal, combined spinal epidural or graded epidural. So then that way we avoid respiratory system involvement. Of course, it should not go above T6. Right, so most of the time we manage with the regional anesthetic technique with oxygen, nasal oxygen. Because with the general anesthesia, all inhalational anesthetics, IV induction, all depresses respiration, dose-dependent manner. Yes. So with the forced expiratory volume, 1 second is less than 1 liter is crucial. So you can't compromise further.
Yes.
So you are not going to compromise respiration.
Yes, and being a senior anesthetist, I think you will not find it difficult to give anesthesia in a severe kyphoscoliosis patient. But I think there are new methods, isn't it? Ultrasound guided methods of giving spinal anesthesia and even epidural anesthesia. So these modalities can be used in the appropriate setting to improve the patient outcomes. Yes.
And add to that like a pulmonary hypertension patient, here also what we have to do is a multidisciplinary serial FEV1 monitoring. Then we know the rate of decline in the chart. So we can then plan the point of delivery at what time to optimal. So from that, it is easy to save the mother and child.
Yes. So basically, can I ask Dr. Visanavasam, these patients as a complication can have pulmonary hypertension per se. They can have it. So do you have any difference of management when you compare another person, simple pulmonary hypertension?
Yeah, this is actually secondary lung disease, right? Yeah. And the problem here is, of course, is rather than is pulmonary arterial hypertension, here the problem is the volume, the capacity is probably the treatment-wise is you have to increase the capacity. I don't think that drugs per se will be very much helpful to increase that.
Yes. Thank you. Mode of delivery, Prabodhana, will it affect?
It's again like now when they have a skeletal disorder, you have to check whether, the pelvis also, whether there are pelvic abnormality as well, but it's a rare thing to happen. So again, I think as Dr. Harshini said, if she can have vaginal delivery, a lot of problems can be sorted. But again, if she needs a cesarean section, as she said now, now being a senior person, it's easy, but then most of the juniors will struggle with the spinal, and also if it happens at night, an emergency. So what we do is, if they come, we'll decide whether she can have vaginal delivery, or now as a primary patient, everybody has 70% chance of vaginal delivery, 30% chance of emergency section. So we always have a plan what to do if she needs a cesarean section, whether she's going to have a general anesthesia, whether they can try for a, they do a pre-assessment, and then we have a plan set in. If she goes to vaginally, no problem. She has a cesarean section, what type of anesthesia is going to give to us, or at least try it, and then we plan it accordingly.
Rishi, any place for inter-procedural non-invasive ventilation or post-procedural non-invasive ventilation in this type of patients?
The post-procedure, because the hyperventilation, everything is related to the pregnancy. So after the delivery, that it's back to the normal level. So post-procedure, usually the patient doesn't need the ventilation. But intra-procedural, yes, it helps, because that will keep the lung ventilation, keep the lung collapse, and keep the oxygenation better. So that will help in the delivery for the patient.
So do we use that DMH inter-procedure NIV in a patient who has been given spinal anesthesia for severe kyphoscoliosis?
Actually, we had several cases, but we managed
without NIV. Yes. All right, okay. I come back to you. 19-year-old now. We have referred this patient to the orthopedic surgeon. It will take about 1 or 2 years to correct this, and she needs now appropriate contraception. All right.
Yeah. So now I come and give a general comment for the future as well. Now, when we looking at any contraception, now we use something called the medical eligibility criteria, depending on the medical condition. Now, for instance, I think the senior doctors here will know that as medical students, we were taught, okay, if you have a cardiac disease or any disease, the best contraception is condoms. Now we know that for per year, there's a 26% chance of failure, right? Whereas OCP, it's 1%, and a loop would be 1 in 1,000. So when let's say somebody with pulmonary hypertension, we say you can't get pregnant, and we offer them a contraceptive method, we know has a very high failure rate, right? Because there were no studies. Now we use something called the medical eligibility criteria, where depending on the criteria, the main contraceptive methods, because again the patient will choose what the best method that she likes, and then we try to give a long-acting reversible contraception compared to OCP. Now for a kyphocolysis, we would prefer a OCP, because I mean it's not it doesn't harm her in another way, right? But let's say pulmonary hypertension or diabetes or something, then we may not be able to give a hormonal one, so we may tend to give a kind of a copper loop or something like that. But and sterilization also plays a part, but we have to be very careful, especially with somebody who has never had a child. When we are offering them permanent sterilization. Now, like you can imagine, like long years ago, when somebody has renal failure, they can't ever get pregnant. But now we do renal transplant, not only live, we do now cadaveric also without any problem in Sri Lanka. Now earlier, heart transplant was a dream, but now we had done 1 or 2. It may not be successful, but in the future it may. So we have to always think about the possibility that the changes might happen. So when somebody who's not never got pregnant, and then we are offering her termination, we have to be very careful, because we have more effective long-acting active contraceptive methods, where if, let's say, by chance there's a method that comes in the future where they can have a baby, then that option is always available. And this is a very easy, tool where you can get it. So you have to kind of like the obstetric, wheel for POA calculation. We can just take condition, and they say there are 4 classes. 1, you can use without any issues. 2, you have to be a little cautious. 3rd, there are more risks than benefits, but 4th is contraindicated. So these are 4 classes. So by taking that, it say, okay, you can use OCP and this, but not, let's say, DMP or something like that. So we offer that. You here, you can't have all this, only you have 2 options. You have to choose one.
Not only for our patients, I think for general knowledge also, as as people, I think knowing about the MEC will be very important. This is when we are advising about contraception, they don't have to have a medical disease. So now we will go for the next section. Another X-ray to be seen. Right. So just a summary, the duration of pregnancy in kyphoscoliosis is similar. Despite increased lung function, decreased lung function with patients with severe kyphoscoliosis, they don't apparently do bad during during delivery and postpartum period. Those are the messages I think we have to deliver. And vaginal or cesarean section can be achieved without any problems, but anesthesia is suggested, as we discussed, and no difference in complications like preeclampsia in these patients. Right. Another chest X-ray here. Again, a patient with about 32-year-old patient coming with shortness of breath. And in this patient, Rishi, we heard bilateral basal fine creps.
Yeah, so when you see the X-ray, even it is not much clear that there are bilateral shadows and short on breath, and with a history of creps, it's a fine creps. So what we ought to think about the interstitial lung disease.
Yes.
And this age group, yeah.
And anything that is associated with this X-ray and this facial appearance?
I will think about it's like a small mouth maybe.
Yes.
So I will think about the connectivity disorder, mainly the sclerodoma.
Yes. And as you correctly said, I think especially we are dealing with pregnancy because they are in the reproductive age group. So connective tissue disorder associated with interstitial lung disease are very, very common in the female age group, in that group. So we have to not to miss, and there are some telltale signs, the basal creps, as well as this facial appearance of a small mouth, thickened skin, and these hands, you have the deformed hands, and this thick scleroderma patient, thick skin. So systemic sclerosis is a connective tissue disorder. CTD-ILD, this is actually the progression of the disease of this patient, and this is the HRCT findings, and there are a lot of fibrotic areas as well as ground glass areas, and changes that are suggestive of most likely NSIP pattern. And these are patterns that we should, it is basically, you don't have to think about much, but this patient has connective tissue associated interstitial lung disease. The take-home message is in this segment is that pregnant patients, even the reproductive age group female patients, when they become shortness of breath, this is one of the important differential diagnoses that we have to consider, and to examine these patients properly. And as Sachini again and again said, take a chest X-ray if you have any suspicion, and then do the pulmonary functions, and then we can come into a conclusion of diagnosis. And in these patients, you can see that in this patient we have performed the spirometry with a value of about 60, and the DLCO is about can't actually see, but anyway it's around 50%. And one or two words about the interstitial lung disease. The huge, there are a lot of causes for interstitial lung disease, but one important thing, especially in the reproductive age group, that we have to think about is the connective tissue associated interstitial lung disease. In the Sri Lankan context, hypersensitive pneumonitis is also an important aspect that we have to think about. And basic assessment will be the spirometry, the 6-minute walk test, the chest X-ray, as well as diffusion studies in these patients to assess severity, and then we have to manage this patient accordingly from there onwards. And this is a typical spirometry where you can see the restrictive pattern. And Rishi, would you like to explain the typical pattern of spirometry?
So the spirometry pattern is most of the people have came across the typical usual normal pattern is high peak and then slowly decline. That's the first one. So what happened in the interstitial lung disease, the damage is in the alveolar area, so the volume loss is there. But the large airways are intact. So the patient will get a very high peak very quickly, but suddenly it come down and the volume loss is there. So the small airways and alveolar affection, there is volume loss. You can see the lower one. So the high peak is there, but it's narrow down because of the volume loss. So this is a typical of the ILD, if I say specifically IPF pattern, not the others. Others also can cause, but this is a typical pattern.
And one cautionary advice, especially when we are interpreting spirometry reports, because if the spirometry loop has not been properly conducted, you can't actually comment on the values or the lung volumes. So the loop should be complete and nicely performed.
And also you have to see how long the patient blowed, because if the patient effort is less, means 3 seconds he blowed out, then definitely there is a volume loss. So we have to make sure the patient has breathe at least 6 seconds to have a reasonable test.
Okay, and this is actually how they have monitored the severity according to the diffusion capacity. We have two methods of assessing the severity of a patient with connective tissue associated interstitial lung disease. One thing is going by the spirometry, where you look at the FE1, FEC, and whatever the cause, FE1 and FEC, if it is less than 1 liter, it is considered as a high risk. And then they have divided according to the DLCO also, high risk, moderate, and low risk. And this is very important when we look at this pregnancy outcome. So they have done this study. This is the adverse pregnancy outcomes, the PROMIS APOs and the severe PROMIS APOs, the fetal outcomes they have measured. And even though in this article they say that especially in sarcoidosis the outcomes are better, but in patients with CTD-ILD they say that the outcomes are not bad. But when we look at patients who are having very severe interstitial lung disease, we can see that all of them have poor outcomes, fetal losses. But fortunately in this group, this is the only cohort that I could find in the internet about CTD, ILD and pregnancy, about 80 pregnancies with 60 patients. But it shows that whenever you have severe ILD, the pregnancy the fetal outcomes are not that nice.
But I think like when you have a connective tissue disorder, it's just lung is one point only, because they have two antibodies, and then they are prone to get what you call growth restriction, preeclampsia. So and they are on like a lot of drugs. So all that has an effect on the fetus as well. So when you say severe, probably that by the time the lungs are gone, most of the other organs all has gone.
Yes.
So lung is one capacity. So if we have a patient with interstitial lung disease secondary to a connective disorder, so if they come for a preconception counts, we have to see what are the drugs they are on MF, and so most of the drugs are contraindicated in pregnancy. So first we have to change them, and they should be disease free. The primary disease should be free for a long time. But when they have interstitial, usually that's mean they have not been managing it properly. So then anyway their prognosis is bad as a patient. When they get pregnant, it's even bad.
Yes, and I was just going to ask you, if this patient comes to you, what we will doing. So basically your principles of management pre-pregnancy would be to probably
So we liaise with they are rheumatologists, as well as if there's a respiratory part, them. And then initially, so if they are disease-free and they are well controlled, we have to see. And then some of them have what we call the secondary antiphospholipid syndrome, so we have to check on that. And some of them have anti-Rho and anti-La positive, where they can have fetal bradycardia and all that. So it's a bit of a more complicated one than the hypochondroplasia or even the sometimes pulmonary hypertension.
Yes, I think. And especially regarding drugs, I think you were very correct. Especially mycophenolate mofetil should be stopped. And if the patient is on methotrexate, it should be stopped at least about a few weeks before that. And you have to give high-dose folinic acid for these patients to prevent unnecessary fetal outcomes. So drugs, having a good control of the disease, drugs and other things will be important. And obviously these patients will be sent to cardiac assessment because they have coexisting pulmonary hypertension. Any concerns there, Dr. Vithanamasan?
Yeah, in a severe forms, even the acute forms, sometimes there may be a huge stress to the right heart. So it's one of the causes for pulmonary hypertension. But early well-treated cases rather rare that we are seeing significant pulmonary hypertension, but we do see time to time. And in case of pulmonary hypertension, of course, we can treat them as pulmonary arterial hypertension, apart from the treating for the lung problem. So that can be done. But I think in these patients, in this stage, in the pregnancy age, usually the pulmonary hypertension is not that severe.
Can I ask Dr. Harshini regarding if this patient now is planning for a delivery or a termination, do you consider specific anything special other than things that we have discussed?
Depending on the case scenario, if there are no contraindications for a regional technique, preferable regional central axial block. Otherwise, of course, we have to give a GA with anticipated difficult intubations and everything have to take into account and give a general anesthetic.
Especially in patients with scleroderma, monitoring the saturation with probes will be very, very difficult, and they have a high risk of aspiration because of esophageal
so many
problems. But
there's no option. Patient coming for a section, so we have to give an anesthetic.
Yes.
So preference is regional central axial.
And they have poor wound healing as well, Prabodhan. Right. So prefer vaginal delivery. Yes. Right. Okay. Right. So this is a very nice article, I think, for the obstetric and gynecology registrars. If you are interested about it, it's recently published in Chest. It gives a beautiful outline of what are the things that you have to do. Monitor the pulmonary function tests, and as you said, do the RAW and the LA, because they are associated with cardiac abnormalities in blocks in whatever the connectivity disorder. RAW and LA will be very useful. And then having a good monitoring, especially the drugs, stopping the methotrexate, stopping mycophenolic mofetales, and probably starting on azathioprine. And regarding steroids, although we have to be careful because they can push the patients towards renal crisis in scleroderma. So these are the things, and vaccination and other things we have to do. And this is actually the largest cohort, and fortunately they didn't have any maternal death. This is actually a tertiary center in the United States, so they have more facilities than us. But fortunately no maternal deaths. Only 1 or 2 patients were in the ICU, but they were able to manage. But fetal deaths, yes, very high amount in severe disease. Right, so the take-home message is, even if you have CTD-ILD, with a multidisciplinary approach and proper control of the disease, if the patient wants to undergo pregnancy, there is a scope. Right. About contraception in CTD-ILD, risk of thromboembolism?
Yeah, so same as earlier, but most of the connective disorder will contraindicate use of contraceptive pills and DMPA or some of the hormones. Now, for instance, if somebody is having SLE and antiphospholic syndrome, the only contraception we can offer is either condoms or IUCD copper, not even the intrauterine systems with progestogen. So, like that we use the MEC. But again, we have to remember that, let's say somebody is who having a high risk of having a problem. Now, sometimes we, as I told you, even though contraindicated or let's say OCP falls to class 3, so getting pregnant is far worse. So even if somebody can't take, they have problems with the womb, they have bleeding, and the only option would be, the next best option would be OCP. It's still class 3, but we may tend to give it, understand the risk, but if she falls pregnant, that's even worse.
So we are coming to the final case. So this is again patient, 21-year-old female, housewife, with diabetes to be complicated. And so anything to say, Rishi?
Yeah, so the lung shows bilateral upper and mid-lower zone cystic shadows. So in the context of diabetes and all, I will consider there are a lot of infection and probably the bronchiectasis as a cause. Then we need to go for a HRCT to further evaluate the patient.
Yes. So, as you correctly said, this patient is having cavitary lung disease, basically bronchiectasis and fibrotic lung disease rather than cavitary lung disease. And this patient has actually had tuberculosis in the past, which is very common in Sri Lankan context, and they can have secondary infections coming in like that. Just 21 years, this is a true patient. So they can come, especially after tuberculosis with bronchiectasis complicating pregnancy. Any concerns, Prabodhana, when this patient comes pre-pregnancy?
Yeah. So the first would be as like when you have bronchiectasis, you have to know whether what is the primary reason for that. So like with the diabetes, tuberculosis, active, reverse, how bad the lungs are initially. And again, so it's easy for me. I just refer to a respiratory physician like you or somebody, and then they will do a proper assessment and tells us what are the possibilities, and then if the heart is affected, Sampath will look after, and then we will, my job is easy, just to liaise with everybody and have a good rapport with everybody, then my life becomes easier. So then only that the problems are, if there's some problem, how to counsel, how to say that, until this such time, you should not get pregnant, and offer them proper contraception. There are a lot of myths around contraception. So those are the challenging things. And sometimes if they are really not suitable for a pregnancy, then conveying that message is the most difficult part.
So we'll just go through this fast, because we have already discussed the principles. One of the most important things, especially in bronchiectasis, is getting a diagnosis, excluding, as you said, tuberculosis and other conditions that can come with bronchiectasis, and about the antibiotic treatment, because there are certain contraindications in pregnancy that we have to consider. Rishi, would you like to talk about it?
Yeah, mainly this bronchiectasis patient, usually what they have is a colonization of Pseudomonas. Yeah. So in Pseudomonas, when we think of Pseudomonas, usually we consider the oral one, the quinolones, but in pregnancy, it's contraindication. Yeah. So that's a problem. So other antibiotics work for Pseudomonas mosa IV. So then it's become problem. So we need to have the vaccination, proper vaccination. Better to prevent rather than treat. Yes. Vaccination, chest physio, reduce the phlegm and everything. That will help to prevent the getting infection rather than treating the infection.
Yeah. As you correctly said, Dr. Prabodhana, most of the things are on our hands, and you have already dished it out to us. So this is actually another patient, a real patient who came with bronchiectasis. This is 38-year-old mother, and this is cystic fibrosis. This is not one of our patients. This is actually cystic fibrosis, which is not common in Sri Lanka. So principles of management doesn't change that much in these patients. So having proper, what we call pulmonary hygiene, arranging physiotherapy, having vaccinations, preventing these patients from having exposure to unnecessary fumes, and at the appropriate state to assess these patients properly for the lung functions as well as the infective taste of the patient, and then when we are prescribing treatment, to be careful about the antibiotics and other drugs, and especially I think these patients are also prone to get pulmonary hypertension, and detecting it early, and it will make a huge difference in our advice that the patient we will be taking, right? So I will not go into much details, because the most important thing is it is same as in a normal adult patient. There's not much of a difference in these patients. Yes, this lady, right? She looks very nice, but this is not actually one of our true patients, isn't it? Right. So this is a 20-year-old, POA 28 weeks, excessive daytime fatigability.
Yeah. So once you guys, colleagues, getting this patient, what's the usual, most of the time usual response is, as your pregnancies progress, you'll get very difficult to do the work and you'll get lazy and all those things. But what I want to highlight here is the pregnancy, as you can remember, the morning lectures, the progesterone level, and that is causing the water retention. So these obese patients, particularly the pregnancy, obese, high BMI, gestational diabetic, hypertension patient have high chance of having a OSA. And as we have discussed a lot of conditions before that, but compared to that all, the OSA have a higher complication, higher postpartum problems, and the problems for the child. So the OSA need to be identified, and also it can be easily treated nowadays. So that will change a lot of the pregnancy-related outcome in this patient. So this patient's typical history, so fatigability is the only thing. So you have to get the history from the husband about the snoring, about the daytime sleepiness, and this patient always, as you know, when there is a high OSA severity, they will get more anxious, sometimes they will get angry very quickly, and so all these can be related to the pregnancy. So in pregnant patient with OSA, you should be careful with the history, and if you have even small doubt to the sleep study, it can be done at chest clinic and NHSL now. So I am having the sleep clinic. So Whatever the patient you have problem, you can send there. I will arrange that. And I also want to mention that in overseas, the two urgent categories for sleep study, one is pregnant patients, second one is public transport drivers. Others, everyone, at least 3 months or 6 months waiting list. So you know that how important here.
Yeah. So basically, I think what you want to highlight is that even a patient who is not having OSA before being pregnant, but due to the hormonal and other changes, they can become pregnant, and they can become OSA. They can develop OSA during the pregnancy, and important to identify the subtle signs, not the main signs. Even if your wife is a little agitated, you have to think about OSA, not scold her, isn't it? Right. So, and these are the things that you have to think about, and because it's diagnosing and managing these patients are very, very important. So I think we have come to the end. Yes.
Yeah, just one comment now as for our obstetric colleagues and the trainees. Now when you are practicing, sometimes like obesity and then medical disorders and all that, then the patient comes for fertility. And sometimes when there's obese, the body prevents them getting pregnant, and then we override that without any proper right. So when somebody is of, let's say, a 28-year-old, who's obese and possibly having OSA or obstetric sleep apnea symptoms and all that, and not getting pregnant, just don't, we tend to give fertility treatment and go, and then shake him pregnant, and it's make them life much more worse. So one of the basic principle of preconceptional counseling is even somebody comes for a treatment, you have to kind of see whether that person is at the moment suitable for a pregnancy. Are there any, what the things which can be changed, we can be modified. So it's best to kind of do that and then offer treatment. Now, for instance, in the UK, if their BMI is more than 30, they can't even get clomiphene. They have to reduce their BMI to 25. So they come every 3 months to the clinic, BMI is still high, so you are not offered treatment, you are sent back. Right? So they have to come to India or Sri Lanka to get fertility treatment, and we make them pregnant and send them back again, right? So which is not, ideally should not happen. So that's one of the basic things, or one of the take-home messages I want to give you, because we see now, because of IVF and all that, some patients who are not supposed, that 58-year-olds are coming with pregnancies, with hypertension, high blood pressure, diabetes, everything. So we see a lot of them. So we have a responsibility towards the thing. So though I said earlier, reproduction is the right, so we have to know where to draw the line as well.
Responsible right. Yeah. It's a responsible right. Okay. So I think we did it in a discussion way, so probably most of the questions are answered. Anything to add, any one of the panelists? Right. So, any questions from the audience? Any questions? Okay. Yeah. Asha is asking. Right.
Sildenafil they are given.
Yeah.
So as well as, is there any risk of pulmonary hypertension crisis during pregnancy?
Yeah, pulmonary hypertensive crisis is actually a possibility. That's the one of the reason. And the crisis actually even from moderate to severe. But now, you don't want to have very severe pulmonary hypertension to go patient to develop crisis, and it's unpredictable. So it's the bad thing of that. So any patient can go into pulmonary crisis with pulmonary hypertension. That's why it's considered WHA class 4. That is the worst sort of problem that can happen. But fortunately, I haven't seen a single patient for last 4 years, or even before that. In my career, I haven't seen a single patient for last 15 or even more than that. From 2007, I'm doing cardiology. I haven't seen a single patient who has gone into crisis. That's a good thing. So it's rare. It's not common thing. And as for the first question, the drugs easily available, and the drug that we are almost always using is sildenafil, and which is very effective. Very effective.
No contraindication, no?
Try to get the right heart function up and the pulmonary pressures down. It's very effective, and most of the patients are going through, even with the second trimester we started, we could take them to the third trimester, almost 32, 34 weeks with sildenafil without much worsening since then. Bosentan, of course, we don't have data at the moment, and we are not using bosentan during the pregnancy. Prostaglandin we can use, but we don't have it freely available. So the only choice for us at the moment is sildenafil.
Okay, thank you very much.
Thank you very much. So I think we just have the quiz. There will be a prize to the winner, the first place, as well as certificate. So giving time for that, I think we can finish this symposium. And thank you very much, Dr. Prabodhana, Dr. Vitanamasam, Dr. Leenage, and Rishi, for having this excellent discussion. And hopefully, I think our audience would have gained a lot. And thank you very much again. Okay, thanks.
A very interesting and a simplified overview of a spectrum of challenging disorders in pregnancy. I thank the moderator and the panel of experts for sharing their valuable opinion with us. In appreciation of their contribution, may I cordially call upon Dr. Mangala Disanayaka, President, Sri Lanka College of Obstetricians and Gynaecologists, to deliver the tokens of appreciation and the certificates. Dr. Niranjan Disanayaka, moderator for the session. Dr. Sundaralingam Rishikesavan. Dr. Prabodhana Ranavira. Dr. Sampath Vittanavasa. Dr. Harshani Lienage. Thank you, sir.